So just to briefly mention the outline for the talk, we're going to look at QT phenotype genotype correlations in terms of T-wave morphology, triggers of arrhythmia, QTC adaptation during exercise, risk stratification, the location of the defect as that translates into phenotype, and management implications I'll save till the next hour, which is the topic of the next talk that I'm doing. So again, the cardiac action potential, we've seen this a bunch, so I won't focus on this too much. But the basis for everything that we discuss, obviously, is the action potential, particularly as it pertains to long QT syndrome. The first three subtypes are long QT1, long QT2, and long QT3. Long QT1 and 2 both affect the IKS and the IKR sodium channels, potassium channels, respectively. Long QT3 affects the sodium channel. Thereby, the phenotypes can be quite different. So this is a slide we used yesterday to really describe the subtype classification and gene frequency. But if you focus here on the ion channel and 1, 2, and 3 being the IKS, as we'll see in a moment, really affects potassium channel function at fast heart rates. So once heart rates, at least in the pediatric population, are about 140 or higher, you start to see very abnormal potassium channel function in IKS long QT1 patients. Long QT2, there's more of a moderate heart rate range where the IKR channel is affected, and then the sodium channel is actually more of a bradycardia-associated ion channelopathy. T-wave morphology, this is one of the first phenotype-genotype correlation papers looking at T-wave morphology in the long QT 1, 2, and 3 syndromes. The long QT1 syndrome has a very broad-based T-wave with almost immediate upslurring of the T-wave. The long QT2 often has a biphasic T-wave with a very abnormal repolarization pattern. Long QT3 is characterized by a long isoelectric segment and a late peaking T-wave. This isn't always the case, but oftentimes you can, if you have these morphologies, you can genotype by phenotype alone. Peter Schwartz was the first to describe trigger events and how those differ in long QT syndromes. If you look here at the y-axis, you're looking at cardiac events that are fatal in patients with long QT1, 2, and 3. Long QT1, there's a predominance of exercise-related events, which makes sense intuitively based on what we know about the IKS channel. Emotion-related and sleep-related triggers are much less common. Long QT3, you see that emotional triggers tend to be a little bit higher, as do sleep triggers. Long QT3 is certainly characterized by sleep-related events. And again, this relates to the specific currents that we're talking about. Just looked at a little bit more in depth here. This is Dr. Schwartz's original article. Auditory stimuli in long QT1 account for a very small percentage of events. Long QT2, it's about a quarter of the events are triggered by auditory stimuli, whereas swimming is really the hallmark of long QT1 syndrome. Somebody that has an event while swimming is long QT1 until proven otherwise. This is a paper we did during my fellowship where we looked at QTC adaptation in the exercise phase. So what we did is we exercised pediatric patients and looked at their recovery QTC values. At rest, the QTC values for long QT1 in the green, long QT2 in the blue, and a control population are seen here. Obviously, the long QT1s and 2s have a much higher QTC interval than the control patients do. If you look at recovery, the main difference between long QT1 and long QT2 is that long QT1 patients are affected really most during the peak of exercise, most during the early recovery phase where their QTCs become markedly even more abnormal than they were at baseline. And that abnormality seems to persist throughout the recovery phase. Long QT2 patients, on the other hand, will shorten just like the control population will. However, late in recovery, they'll begin to show QTC abnormalities that are similar to what their baselines are. What we showed in this paper are that a QTC value at 7-minute recovery of more than 460 is a relatively good sensitivity and specificity test for long QT1 or long QT2. Looking at this a little bit differently, and I'll go back to this slide, if you examine the difference between the QTC at 7 minutes and at 1 minute, this is a useful marker for distinguishing long QT1 from long QT2 syndrome. So if you have a patient that has a QTC that's abnormal at 460, they've sort of failed one test in terms of having abnormal QTC adaptation. If you're wanting to know whether those patients are long QT1 or long QT2, you could check the delta QTC, which is the QTC 7 minute minus the QTC at 1 minute. If that QTC is more than about 30 milliseconds, that's very suggestive of long QT2 syndrome, whereas if they're about the same, as you see here in long QT1, that suggests it's long QT1 syndrome. So risk stratification is certainly a hot topic for clinicians. Sylvia Priori, about 10 years ago in the New England Journal of Medicine, published data on event-free survival and how that differs in the different subtypes of long QT syndrome. Prognostically, long QT1 patients had, these, mind you, were patients that were not treated. Long QT1 patients had the best event-free survival curves, followed by long QT2 and then long QT3. If you look at gender classification and subtype, you see that the best prognostic patient population were male sex of long QT1 patients, male sex and a QTC of less than 500. These are considered the low-risk patients. If you're female sex and your QTC is less than 500, it's still relatively good prognostically, but not as good as male. Female with a QTC of 500, you see that the survival curve begins to diminish here. And then worse prognostically is male sex and a QTC greater than 500. Long QT follows similar but slightly different patterns. Again, male with QTCs that are not very long are best prognostically, and worse prognostically are female with QTCs that are 500. That's relatively the same. And then here in the middle, you see that the males with QTCs greater than 500 also are considered high risk in long QT2 patients. Long QT3, the males with QTCs that are prolonged are considered the highest risk for sudden death. Graphically, in a pyramid form, the low-risk patients are down here, and notice that QT subtype is part of this analysis at every phase. QTCs lower than 500 are best prognostically if you're male in long QT2 or if you're male or female in long QT1. Highest risk groups, risk of having an event of more than 50% were patients with QTCs of 500 that were long QT1, long QT2, or if you were a male sex with long QT3. These are the highest risk patients. Gene location also matters. Dr. Moss, who was involved in the long QT registry, published this data about 7 years ago in Circulation, looking at where the mutations are, and this is KCNQ1, the long QT1 gene population. Where the bigger the dot, the more mutations they found in their patient cohort. And you see that C-terminal mutations here by the terminal end of the protein had less of a phenotypic effect than transmembrane proteins did. Transmembrane proteins, and we'll see later that cytoplasmic linker proteins also had a pretty profound effect on phenotype. So where the gene is part of our risk stratification conversation when we meet with patients and families with long QT syndrome. So phenotype-genotype correlations are really well established, probably the best established in long QT syndrome, and are the cornerstone of therapy, the cornerstone of risk stratification. Clinical knowledge of genotype effects really guide our clinical approach. And risk stratification really hinges largely on genotype. It's a very important piece of information that we use. Thank you.
Thank you, Peter. There are some questions. Yes, please.
Thank you very much, Peter. Actually, I'm going to bring it back to the previous talk. What you presented is that with different genes, their response to some environmental stress, be it exercise or emotion or gender, affects how this gene translates into a particular phenotype or risk. So going back to the lab where the different genes actually didn't do much to the action potential duration. So the lab environment is a pretty controlled environment. How do you bring what you see clinically in terms of how these genes are affected by the environment into the lab? And how do you study the effect of these different mutations in response to environmental factors like high sympathetic tone or pressure overload or gender?
I'll let Dr. Zimmer take that one first if you'd like.
My second talk today is on this issue. So some people, for instance, the pH value can be important to increase persistent tolerance of drugs, or antibiotics, and such things, or splicing, and so on. It's very beta subunits. It's very difficult to analyze all those factors that may affect further function in the in vitro system. So it's simply not possible actually. It is possible, but it takes a long time to do that. But you're right, it's a big problem.
Yes, Professor.
I was interested in the location of the mutation in the gene and the actual mechanism by which that translates into phenotype. We have interest here, a group for looking at molecular modeling and looking at the three-dimensional structure of the protein.
Right.
Do we know, had that been done?
To my knowledge, no, but certainly that is the next step. As Dr. Zimmer showed in the sodium channel, mutations that are even in the C-terminus can affect the configuration of the transmembrane protein as well. So it depends. We certainly know that patients with mutations here versus there can be very different phenotypically. Patients in the same family with the same mutation can be different phenotypically. So it is more complicated than we understand, I think, for sure.
Wonderful talk. I actually feel concerned about the question that just has been asked concerning how we can recapitulate what we see on the whole heart on a single cell when we do mutations. For instance, mimic hypertension or to mimic overload or whatnot, what we do as biophysicists is we attach the cells, and by stretching the cells, we can basically mimic when the heart is, when we have an increase of the heart load or an increase of the, if you have exercise training, for instance, you have more blood that goes in, so you stretch your cells, and that will give you more or less like similar situation. And to get back to and by the way, Moss, is that Rick Moss from Madison? This guy is a biophysicist, by the way. He does also attaching single cell that is intact, and he does the mutations, and he does patch clamping, and he stretches the cell, and he measures basically what happens at slack length and at stretch, which means slack length is like when you're just walking, and stretch means you're doing exercise training or you're high activity exercise training. I just feel concerned by the question, that's why I wanted to. Thank you.
Along the same lines, we sometimes use the animal models where we introduce the mutation and then we have a living organism where you can exert all the different environmental conditions, try to mimic the best possible extent, and you have the animals carry that mutation. At that level, though, you can't mimic all of those polymorphisms that are present in the human. You may be adding to the effect and you have a long way to go there.
I think that is the most difficult thing to analyze is the effects of more than one gene. Oftentimes, clinically, what we do is we pick an index patient to do testing on. We find one mutation, let's say, not realizing that another family member may have a different important mutation that really alters the way we think about the index case mutation. So I think there's a lot more to come on that.
And there's this whole field of modifiers genes that
Right.
don't just again.
Sure.
I have a question regarding beta blocker therapy in long QT3. So is it still a gold standard to treat the patients with beta blockers?
I'm glad you asked that, because
I don't know. I'm a natural scientist, but I wonder because events occur during sleep.
yeah.
So at the low.
So
heart
why would
rate-
you give them a beta blocker?
So, yeah, because
I'm
it's-
very
beta-
excited to answer that question, though. The next talk I'm giving has slides that discuss beta blocker therapy in long QT 1 and 2 and 3. So great question.
Okay, if we have no more questions, we'll move on to our next speaker.
Thank you.
It's a great pleasure. Thank you very much, Dr. Aziz.